Good evening and welcome everybody to this live EMAS session with some experts about the latest FDA decision. I want to introduce to you Angela DeRosa. She is a board certified in internal medicine, women's health specialist, CEO and founder of Hormonal Health Institute in the United States of America. And she is also an advisory board EMAS member. Also, Professor Petra Stute, she is Deputy Director of Gynecological Endocrinology and Reproductive Medicine, Head of Menopause Clinic in Bern, and the current President of EMAS. And also Dr. Eleni Armeni, she is Board Member EMAS, Editor Maturitas, Honorary Assistant Professor in Birmingham, and also Consultant Endocrinology. My name is Dorenda van Dijken. I'm a gynecologist in the Netherlands, chair of the steering group Women's Health, and also EMAS board member and guideline writer. We're going to have a live conversation, not a lecture. And what we're going to talk about is what changed the discussion due to the newest FDA decision, because the science has not changed, but the conversation has. And the science was there all along. So, Angela, could you briefly explain what the FDA changed?
So honestly, I think this is a perfect example of hell freezing over because never in our wildest dreams here in the United States did we ever think that the FDA would come out as clearly and staunchly and saying that, oops, by the way, we were wrong. And it was really amazing when the FDA commissioner, Dr. McCary, came out and quite strongly stated that, honestly, that he said that the Women's Health Initiative really irreparably harmed women's health for the last 2 decades, stating that 70 to 90 million women were denied the health care that they deserved, and significantly called it life-changing, even to the point of stating that hormone therapy was so vital and nothing else other than hormone therapy, other than vaccines and antibiotics, really have as much positive anecdotal and evidence-based medicine to support healing women and caring for them and being truly life-saving. And to further go on the editorial on this, he said that doctors here in America went under this fear machine and the groupthink around it became so tremendous, and that he called it an American tragedy that the FDA finally needed to correct, because it was time that they really did a reprisal of that data and come out. Honestly, it took, here just shows how slow government works, 23 years to correct the information that was being presented, because for those of us who understand statistics, the data was always there all along. It took them 23 years to correct it and reverse their stance and remove now the black box warning, not only on vaginal estrogens, which we all thought was going to be the case in July when they first started entertaining this, but all estrogen therapies, which was a huge win.
Yes, definitely. And it's all due to the WHI findings. And Petra, can you explain how did the WHI findings influence care across Europe?
So indeed, initially, the WHI findings led to a dramatic decline in menopausal hormone therapy use across Europe, as many clinicians and also scientific societies initially overgeneralized the reported risks. And this created years of uncertainty, undertreatment, and widespread fear among women, but also, and I must say until today, among healthcare providers. Over time, European experts, among other international experts, reassessed the data, corrected misconceptions, and moved forward toward a more nuanced, individualized approach to menopause care. So, summarizing, I would say in Europe, we did, of course, not ignore the WHI, but we as others learned from it and evolved with the evidence.
Yes, for sure. And Elena, would you say there's been a real progress in menopause awareness in Europe?
Absolutely. Even with the data originally published by WHI, menopause awareness in Europe started slowly, meaningfully growing. The reason behind this, as Petra said already, we learned about how the results of WHI in reality should be interpreted. The societies engaged time, engaged effort in order to create new guidelines based on the reanalysis of the WHI once the results actually started making sense. And this new guidance started being the driving force of the care in Europe. But also, in many countries, there is a search for public conversation and destigmatization when it comes to menopause. I'm working in the UK. UK is a big example when it comes to the menopause cafes, when it comes to women speaking out loud about their problems and being encouraged, being given the strength to speak and ask for care. Workforce has changed. Menopause is considered as a big part of women's life that needs to be taken into consideration, and also the policies around workforce when it comes to women who actually at times suffering from menopause symptoms. They have been adapted, and slowly Europe has started moving ahead, seeking a better quality of healthcare even after the menopause.
Yeah, definitely. Thank you. And I was also curious with all three of you, starting with Angela, how did you react when the decision was announced?
I wanted to get on the rooftop and go, hallelujah, praise Jesus. But it's the other thing I wanted to start was like, well, I told you so. I mean, as someone who is a woman who went through premature ovarian failure at 35 and been studying this area for 30 years, it was clear as day that hormones have always been beneficial. They just so badly misreported it. But it's incredibly difficult to get glib about it when you actually think of the 70 to 90 million women who have been irreparably harmed by the lack of hormone therapy. And just a little bit of additional context here. During this time, I was working at Procter & Gamble on trying to get a testosterone patch approved for women. We have yet to get an FDA commercial product here in the United States. So not only did that Women's Health Initiative stop women from going on their estrogen products, but it also stopped the approval of a testosterone product here in the United States for women, which we desperately need. So the impact of that was tremendous. So I'm tremendously relieved and going, finally, we have the ability to move forward and hopefully affect change. But it was tempered with a lot of anger. So
Yeah. And Petra and Elena, how did you react?
Yeah, so my first reaction to the FDA news was a mix of surprise and relief. After years of uncertainty and especially the mismatch between authorities and scientific evidence, it feels like an important step toward clearer guidance and better aligned clinical practice. At the
Yes.
same time, I'm aware that many questions remain, and we will need to interpret the implications carefully for real-world patient care. But overall, it's a pivotal moment that will likely reshape discussions in women's health.
Yes, thank you. And can you, Elena, also
So
tell?
from my side, my first reaction was, wow, well done, finally.
Yeah,
Right
finally,
after,
definitely.
exactly.
Yeah.
Right after this, I started considering my colleagues, and it is an empowerment for the doctors that they do not feel as restricted by the guidance in order to prescribe and recommend specific types of medication. At the same time, though, being not too long ago a trainee in endocrinology, I started thinking about the fact that every woman, or at least majority of the women, will start asking for HRT now. And I'm not certain if our early career colleagues are ready to prescribe it. So education was the big question that dropped into my mind. And we need to deal with this issue, prepare the general practitioners, prepare the early-career endocrinology, gynecology colleagues, even the mid-career if needed, because now that the guidelines are adjusted, the FDA is adjusting the approach, everybody needs to actually learn what is the right way. There will be some confusion, at least in the trainees of either specialty, in what to give, how to give, and for how long. So that is a task for us.
Yes, that's very good of you to mention education. That's important. And Petra, what does the latest science actually tells us?
So actually, the science on MHT, so menopausal hormone therapy, shows that for healthy women under the age of 60 or within 10 years of menopause, the benefits generally outweigh the risks. So we now understand that timing matters profoundly. Starting therapy early may be associated with cardiovascular and cognitive benefits, while late initiation carries more risk. And we have modern new formulations, we have individualized dosing that further improves safety and tolerability. However, and I think that's really important, we need to communicate evidence-based numbers when talking about risk reductions with the help of MHT, for example, for cardiovascular disease and also for dementia, as the numbers provided during the FDA press conference were, let's put it this way, not that accurate. But overall, MHT is one of the most effective, and that has been proven by many, many studies, most effective, and it's one of the well-studied treatments in midlife medicine that we have and that we just should use appropriately.
Yes, correct. And a question to all three of you again. Well, correcting the past mistakes doesn't mean that there is no caution. So could you, all three of you, reflect briefly on this? How are we going to avoid going from one extreme to another? Petra, maybe starting with you, please.
So I think that all of us, we are very sure about that MHT is a powerful treatment, but it's not a cure for everything. So indication really matters. So we do know that menopausal hormone therapy is primarily indicated for menopausal symptoms, such as vasomotor symptoms, as hot flushes and night sweats. And also the vaginal estrogen therapy is indicated for women suffering from the genitourinary syndrome of menopause. And as already mentioned, in women under the age of 60 or within 10 years of menopause, MHT is also effective for prevention of bone loss and fracture. And not to forget those women that experience an early menopause or premature ovarian insufficiency. Here, MHT is clearly indicated until the age of physiologic average menopausal age.
Okay, yeah. And Elena, what do you think about clinical implications?
So when it comes to HRT, the clinical implications are pretty much to consider that it cannot be one way of treating each and every woman. So personalization is something very important. There is a slight risk when it comes to a uniform adaptation of the guidelines that doctors are likely to consider that it's only one way to treat each and every woman, but the risk factors need to be taken into consideration, including cardiometabolic, thrombotic, the risk for breast cancer, the bone health risks. All of this need to be reviewed before initiating menopause hormone therapy. The non-hormonal or transdermal options are still available, can be considered. Menopause hormone therapy is available, is indeed first-line treatment, but it's definitely not for everybody. So we need to make sure to keep an open eye about the patient's profile. What does the patient need and what does the patient want? And also, despite the fact that the box warning has changed, the learning of AWHI was the timing hypothesis, which is a major outcome that we can always use to at least be guided to some extent when we're treating our patients. So the age of initiation and what is considered as the right timing to start the treatment, potentially what is the guidance in order to safely continue. In any case, reassessing the risk factor profile, taking into consideration what the women wants at every stage of her lives, these should be the driving factors rather than what the doctor thinks is the right thing for every woman.
Yeah, so HRT is all about personalized medicine. And Angela, has there been a shift in the US in the recent years?
Well, and I think that question is valid because why would the FDA all of a sudden make the decision now? And I think there's a lot of political pressure, a lot of
Yeah.
academic pressure. And I honestly believe that it's our patients that are driving a lot of the shift and change because you're seeing an explosion in longevity medicine, functional medicine, integrative health, whatever you
These
want
should be
to
the
call it
driving
and frame
factors
it.
rather than what.
And that having occurred in the United States and a lot of people looking at longevity and wellness is driving more of the conversation. And I think it's forcing physicians and physician groups and societies to relook at the way they've been looking at it, because you have a lot of influencers and folks with big mouths who are out there talking and questioning a lot of what's been told. And I think it's caused that reevaluation of the data. And as we know, menopause is having a moment, in particular in the US. We have private equity spending a lot of money, and unfortunately, altruistically or non-altruistically, it's an opportunity. And if it can drive more of those conversations, I think it's really valid. So this has been kind of coming, and we saw the reversal with the black box warnings on testosterone for men with the Traverse study, and now kind of a reevaluation. So we always come second in this regard. And I'm just glad we finally made it. So.
Yeah. Yeah, and it's clear that HRT is not a one size fits all. And I think we need clear voices based on evidence. And what do you think, Angela, is the role of clinicians and societies in this?
Well, clearly we should be taking some relook and reevaluation. Unfortunately, the medical societies here in the United States, at least, have not been kind to doctors who have been very pro-hormone over the last couple decades. And in fact, some of them, those guidelines can also lead to board actions and board decisions because of folks not following those guidelines. And I think there needs to be a very loud mea culpa coming out of some of those societies and organizations, and really the education to not only patients, as we've discussed and Elaine has talked about so beautifully, but also to clinicians, because medical school education, residency education, all of that dropped right after the Women's Health Initiative. We have 2 decades of clinicians that don't have a clue about hormones or menopausal medicine. So I think the biggest thing right now is an opportunity to educate clinicians and empower our patients to question our clinicians and the information that they've been negatively given over the last 2 decades.
Yeah, for sure. And maybe the role of clinicians and societies is different in Europe than in the US. So what is your reflection on that, Petra?
So I think that professional societies like EMAS, that they play a real important role in providing calm, clear, and consistent leadership in menopause care. And they help to translate scientific evidence into practical guidance that clinicians and the public can trust. And I think that's very important. So by setting high standards and harmonizing recommendations and dealing with misinformation, these societies may and have to ensure stability in moments of uncertainty. And I think that as a society, as a scientific society, we have a duty to lead and not to react with clarity.
Yeah, that's true. And I would like to do a shout out to all the participants and listeners. So please leave in the comments and in the chat behind what would your suggestions or ideas are about what EMAS can do for you in Europe. And we'll take that into consideration, of course. And Elena, what do you think of the role of societies and clinicians in the aspect of education?
So the clinicians need to seek actively updates on their education. The role of the societies, though, needs to be an organized approach to the clinicians that need education the most. And we have already some plans when it comes to our society, but
Yeah, we do.
absolutely. But as I think it was Angela who just said, there is a very big cohort of mid-career and a huge cohort of early career clinicians that actually are afraid of these medications. So when it comes to these clinicians, the clinician cannot restore the patient's feelings against HRT if the clinicians themselves are scared of HRT. So they need to start learning on how to use the medication again from the scratch. I'm slightly concerned in how easy it will be when it comes to mid-career clinicians who learn differently for so many years of their professional life, but at least the new generation of gynecological endocrinologists, either gynecology or endocrinology or GP, they need to know to trust what is out there, trust the guidance, trust the guidelines, seek education, and ensure that by listening to the patient and adapting what is guideline available out there, the outcome will be positive.
Yeah, that's a very strong, powerful message. And I think that the future of menopause care is timing, individualization, and also evidence. And I would like, of all three, you experts, can you give me a final line on this, starting with Angela?
So, sorry, I was muted for a second. So to really reemphasize what Elena is, that we really do have a responsibility to our patients. We always have, and unfortunately, we were misguided by the organizations that we were taught to trust. And I think the newer generation, we question everything, and which is a good thing. And that's how we move forward with innovation. And it's really going to take a multi-pronged approach to get us where we need to be with that education of the clinicians at all the levels, not only in the primary care specialties, but also in the subspecialties, so they can support us and not be a hindrance as we're relearning things, and really empowering our patients. And what does that look like on a consumer level so that they get all the proper information? Because I mean, we here, at least in the United States, a lot of the people here do not trust government. They don't trust a lot of authoritative bodies or a lot of those things. So I think we have a lot of work, but we have a great opportunity. I guess they always say when crisis comes opportunity. And not only looking and reevaluating hormones themselves, but the individualization and personalization of medicine. And I just I know that we're here to talk about estrogen and progestins in particular, and progesterone, but then throwing out that there's a lot of education that needs to occur on testosterone in women. And that's my hope for the future, is understanding the role and the important role that testosterone plays into women, and using this to parlay that right on top of it. So
Yeah, and proper products for women as well.
exactly.
Yeah. Elena, a final line, please.
The when and the how to treat your patient needs to be matched with what they actually want from life and health itself.
Oh, yeah, that's a short line. Very nice. Yeah. Petra, you as EMAS president, a final line, please, or a message.
I think it's very, very important that we should not replace misinformation now with overconfidence. And I think all of us working in medicine know that an appropriate care is always a balanced care. So we should stick to that.
Yes, for sure. And as EMAS and the current EMAS board, under your guidance, we have big plans for better visibility and affiliation, but also education and cooperation with other societies. So we still have a couple of minutes left, but I think most things were said and done in this very nice first live EMAS conversation. So I would like to thank at first all the participants, and again, please give us your ideas, suggestions, or what EMAS can do for you, and healthcare professionals. We need more EMAS members as well. So become an EMAS member and join us in our forces. And I would like to thank the experts, Angela DeRosa, Eleni Armeni, and Professor Petra Stute. Thank you for this conversation, and I hope everybody found it very enlightening, inspiring, and helpful. And I wish you all a good evening and a very nice weekend.
And also thanks to all of you. Thank you very much.
Thank you.
Thank you.
Thank you.